Good morning, one and all. First of all, I would like to thank Professor Sharma for having invited me here. So I'll be talking on neuroimaging techniques, specifically neuro-ophthalmology. So briefly on the indications of neuroimaging, visual acuity or field loss, motility disorders, pupillary abnormalities, pain syndromes, papilledema, or any new onset of recent onset of headache. So a brief backup of the information. CT using ionizing radiation like X-rays are good for bony structures and blood in situations like trauma, calcified lesions like tumors, optic disc drusen, or an acute subarachnoid hemorrhage. MRI is good for soft tissue lesions, especially neuro-ophthalmology in optic neuritis to rule out multiple sclerosis, and as well as evaluation of papilledema, including MR venogram, as well as detecting other optic nerve soft tissue injury and muscle entrapment in injury. Other indications are listed here. So basics about T1 and T2. In T1, every fluid is dark. You can see the vitreous as well as the CSF being dark here. And then orbital fat is bright though, which is going to impede our findings, which we will see shortly. T2 is all the fluid is bright, CSF and vitreous is white or hyper intense, and orbital fat also is bright here. Again, we will see how it can be suppressed. So pathology, what is black and white on T1 and T2? Black on both T1 and T2 will be calcium, gas, rapid flowing blood, and cortical bone. Calcium lacking significant water has less amount of hydrogen atoms, so it appears black, and similarly cortical bone, rapidly flowing blood. There is no enough time for the protons to give back the signals, and it rapidly flows away, so the MRI cannot pick up the signals. So a rapidly flowing blood will show black on T1 and T2. And what is white on T1 and T2? Subacute hematomas, stationary or slow moving blood like a thrombosis. It will show up as bright signals in MRI. Similarly, fat, lipoma, melanin, and gadolinium are bright in T1 and T2. Gado shortens the relaxation time and leads to breakdown of the blood. It concentrates on situations where there is breakdown of blood-brain barrier like neoplasm, infection, or inflammation. Though normal enhancement can be seen in the nasal mucosa, being a very vascular structure, as well as the extraocular muscles, and also the pituitary gland. The posterior part of the pituitary gland is fat laden, and so it appears bright in normally even without contrast. So discussing about some of the newer strategies for neuroimaging, we have the short T1 inversion recovery sequences which suppresses the fat. We have fluid attenuated inversion recovery or FLAR images. We will see where it is indicated, especially in cases of multiple sclerosis. Basically, it suppresses the fluid. We have diffusion weighted images. Restriction of we are measuring the restriction of diffusion of water to detect the pathology. We have MR spectroscopy or MRS. We have diffusion tensor imaging, which Dr. Rohit was discussing. Of course, we have functional MRI as well as other. We'll see the stir imaging sequences. So basically, stir is a short inversion T1 inversion recovery sequence. So we'll see what it is indicated. This is a normal T2. You can see here, this is a normal T2 sequence, a coronal image, and you can see the nerve in the center and the surrounding fluid which is bright, which is seen in T2. So this is normal and it is called as a target sign. But what happens if there is a optic neuritis? We see there is a loss of this hypo intensity in the nerve, and we see the whole thing becomes hyper intense. This is called as loss of target sign. Supposing we have the fat which is fully bright here, we will not be able to appreciate this loss of target sign, and everything will become bright. We need to pick out the bright optic nerve, and we need to suppress the fat surrounding it. And so this is called as a fat suppressed stir image, which is useful for bringing out optic neuritis. So as for the radiologist will give you this image for optic neuritis. So next most important thing is the FLAR images, fluid attenuated inversion recovery sequence. So what is this fluid attenuation? So discussing about the T1 and T2, T1 is used for normal anatomy and T2 is used for pathology. So good pathology is seen in T2 images. But what happens here, if in T2 the fluid and the CSF is very bright and we want to see something like a bright plaque in multiple sclerosis in T2. So this is a flare image, and supposing this fluid, this CSF was very bright here, we will not be able to appreciate the multiple sclerosis plaques in T2. So we need to suppress the fluid, and that is what this T2 does. Similarly, you can see this these bright hyperintense signals, the plaques, multiple sclerosis plaques, after suppressing the fluid in the ventricles, and that's how the flare images helps us to pick out all these multiple sclerosis lesions. So you may ask us, now you have suppressed all the fluid is appearing dark. How do you differentiate a T1 and a T2 in this? So that's a very valid question, because T1 also is fluid is dark, T2 also we have suppressed here, the fluid is dark. How do we know this is T2? So a simple algorithm is white is white and gray is gray in T1. Gray matter is gray and white matter is white in T1. The reverse is true in T2. So you can see here T2, the gray matter is white and the white matter is gray. And so that's how we roughly identify what is T1 and T2 even in the presence of a flare images. So the next most important concept is a diffusion weighted imaging. So this is a very old CT which shows that you can see a hyper dense CT, we use the term density, hyper dense lesion in the posterior cerebral artery territory leading to a macular sparing homonymous hemianopia. So nowadays we use MRI, and what you see here in this picture is a very old chronic infarct, and CT is very bad in picking up very acute infarcts. So what do we do instead? We try to use MRI images. MRI images are also good in picking up acute infarcts, but not the very hyperacute infarcts. So MRI may show positivity or hyperintense lesions in the occipital lobe maybe in the first 8 to 12 hours or even 24 hours. But we have the golden period of 6 hours to thrombolyze the patient to recover the fields. So what we need is a diffusion restricted sequence. So what is the principle of diffusion restriction is whenever there is an ischemia or the infarct, the cellular diffusion is restricted and there is edematous brain and the fluid accumulates and it appears as bright diffusion weighted images. These are all called diffusion weighted images. How do we identify the diffusion weighted images? You can see the normal MRI sequence, you can see all the details very clearly, whereas in the diffusion weighted images, you are not able to see the other structures of the brain clearly, but what you see only is the bright signals or the hyperintense signals in a hyperacute infarct. So whenever you see a patient with acute, the patient comes within 2 hours, I cannot see on this side, or I cannot see this, and you see a homogeneous field defect, rush the patient to do a diffusion weighted imaging and immediately send the patient to the neurologist to thrombolyze, and that is the value of diffusion weighted imaging. So this is another diffusion weighted imaging. You can see all the pixelated brain signals. You don't see the accurate brain details. You see them as pixelated signals, and you can see however, you can see the bright hyperintense signals of the infarct. So other not so recent but which has been relatively used commonly is the MR venography or the MR venogram to detect venous sinus thrombosis. This is a normal MR venogram. You can see all the sequence, all the superior sagittal sinus and the transverse sinuses. Remember that MR venography is a non-contrast image. You don't need to put a contrast. It's by special sequence and software they do it.
Mahesh, you might have to conclude.
Yeah, I'm wrapping up. So you can see here in a pathology there is a thrombosis. You cannot see the signals. MR spectroscopy is one more information which gives biochemical information. When you cannot differentiate, you can see all these biochemical markers, choline, creatinine, N-acetyl, acetic acid. All these give specific information which the MR, the radiologists use to give the biochemical characteristics. And we also use the 3D reconstruction images to see the vascular structures, and the radiologists are using this. And in case of hemifacial spasm, we use what is called as a MR neurogram to pick out all the finer details of the nerves. So as for the MR neurogram to the radiologist, if you see any hemifacial spasms, and you can see Dr. Rohit has already described that diffusion tensor imaging to pick out the white matter tracks and see if there is any loss of the white matter tracks. Thank you very much for your kind attention.